Good afternoon. Another unusual topic at the fag end of the day. Hope I'll try to do some justice to it. The duodenum preserving pancreatic head resection, or DPPHR as it is called in short, was first described by Hans Beger in the year 1989 for chronic pancreatitis to deal with inflammatory head mass. And thereafter, this procedure is known as Beger's procedure, quite popular with chronic pancreatitis. But then in Takeda in 1993 used or extrapolated this procedure, extended this procedure for benign or low-grade malignant tumor of the pancreatic head. So in this presentation, basically I'll be dealing with the idea or the rationale behind DPPHR, the indications of DPPHR, and the technique of it, and then how does it fare vis-a-vis pancreatic or duodenectomy, and the current perspective and my take on the procedure. Advanced imaging has seen a spurt in the diagnosis or incidental detection of benign tumors or cystic tumors to the extent of 8% in a very busy hospitals and the radiology department. And PNET is another entity which is detected more frequently with this kind of imaging, and this comprises about 2% of all pancreatic neoplasms. And all this benign and premalignant lesion do account for about 15 to 20% of all pancreatic resections. So therefore, this is not a small number by any means. The question is, why DPPHR? One reason could be pancreatic resection or pancreatic or duodenectomy is a formidable procedure with an associated mortality of 2 to 4%. And major or minor complication up to 40% in various series. However, this figure is no different with DPPHR, so obviously that is not a reason why you would recommend this DPPHR. Where it differs significantly is the long-term endocrine and metabolic outcome. New onset diabetes mellitus has been reported in 14 to 20% of patients following pancreatic or duodenectomy. Similarly, new onset PEE is to the tune of 34 to 45% following pancreatic resection, the conventional pancreatic or duodenectomy. And new onset steatohepatitis or fatty liver in about 20% in the long term. The new onset diabetes mellitus following PD is because of the hormones that control the glucose metabolism significantly get reduced following resection. And then this duodenectomy results in a disconnection of the duodenoppancreatic neural axis that disrupts the relationship between interdigestive GI hormone release and insulin secretion. Similarly, pancreatic enzyme insufficiency or PEI is following PD is because of significant decrease in the gut and pancreatic hormones due to enterectomy, duodenal or jejunal excision, or because of the diversion of the following gastrojejunectomy in pancreatic or duodenectomies. The exact mechanism of steatohepatitis is not known, but this could be because of dysregulation of adipokines and hormones and increased insulin resistance and change in the upper gut microbiome. So basically what we understand that duodenal and proximal jejunal resections are the key metabolic and signaling centers that coordinate GI hormone release. And organ preserving surgery, namely this DPPHR, is to maintain duodenal and jejunal integrity so as to minimize the immediate and long-term endocrine and exocrine effects of pancreatic or duodenectomy. About the indications of this procedure, most common are the solid and cystic lesions of the pancreas and neuroendocrine tumors. Just to give you a perspective, this is one series of 30 patients where the most common indication again was the serocystic neoplasm, accounting about 33%, followed by pancreatic solid pseudopapillary neoplasm, then MCN, IPMN. All these account for, all these are the main indications of DPPHR. And the median tumor size in this particular series was about 3.6 centimeter, ranging from 2 to 5.5 centimeters. Now, just to tell you about this technique, what exactly is the DPPHR? Here you can see the pancreas is divided. Pancreas is divided at the neck along this or over this mesenterico-portal axis. Then this pancreatic head is excised, preserving this pancreaticoduodenal arcade, anterior and posterior pancreaticoduodenal arcade. And for this, in the original DPPHR, what Vegas did was retain a part of the pancreas close to the C-loop of the duodenum. So this is called partial DPPHR. When you remove this patch of the pancreas from the C-loop of the duodenum, it is called total pancreaticoduodenectomy. Total DPPHR. So roughly about the technique, this could be performed by open surgery, laparoscopic or robotic surgery. This tunneling is done as in pancreaticoduodenectomy. Then the pancreas is transected at the neck and the uncinate is mobilized as again in the conventional pancreaticoduodenectomy. And about this arcade, it is important to retain the anterior inferior and the entire posterior duodenal arcade, because that is what is important for the supply of the duodenum as well as to the bile duct. This anterosuperior you can afford to divide because that sort of helps in, that is for technical ease. You can divide that, but then this remaining you have to retain. And in order to preserve the bile duct or the safeguard the common bile duct, one might use ICG cholangiogram. And then, if required, if the surgery is done for an ampullary tumor where the CBD, ampulla and the duodenal segment has to be excised, particularly when indicated, not in all cases, then intraoperative ultrasonogram is used to define the tumor location as well as to have to define the margin. Again, frozen biopsy is very important, particularly to exclude malignancy as well as to have a safe margin. And then the MPD on the proximal side is ligated, and the distal, of course, the management of this pancreatic stump is similar to what you do in pancreaticoduodenectomy. It could be a pancreaticojejunostomy, and in some people have even done a pancreaticogastrostomy. Then hepaticojejunostomy of the duodenal repair is to be done as and when indicated. Again, a picture I have downloaded from the net just to give you an idea about what this particular thing is. This is a MR picture showing a benign tumor in the head of the pancreas. This is a 3D reconstruction. This is again a cholangiogram, ICG cholangiogram showing the bile duct. Here, this is after the resection. This is the bile duct, this is the portal vein, and this is the pancreaticoduodenal arcade and the duodenum. So again, comparing the DPPHR with the conventional pancreaticoduodenectomy, and this is important. This I've taken from a review article published recently by Vega group himself. So as you can see, the operative time is roughly about 5 to 6 hours, no different between the two procedures. Intraoperative blood loss again is more or less same. Need of blood transfusion, of course, is slightly less in this DPPHR group. So is the operative mortality as compared to pancreaticoduodenectomy. The incidence of pancreatic fistula is similar in both the groups. Duodeноgastric, delayed gastric emptying is again similar. Biliary fistula, in fact, is slightly higher. They may not be statistically significant, but it's slightly higher in this DPPHR group. And the reintervention, surgical reintervention is less as compared to the pancreaticoduodenectomy. But what is important is the delayed outcome of these two procedures. So new onset diabetes, this I have already mentioned, in a follow-up of about 2 to 3 years, the new onset diabetes is 14 to 20% in the pancreaticoduodenectomy group, which will be less than 6% in this group. A new onset pancreatic enzyme insufficiency, again to the tune of up to 45% in some series, whereas it is less than 7% in this group. Fatty liver is again significantly higher in this PD group as compared to DPPHR group. But what is again worrying is the long-term biliary stricture in the DPPHR group, 8.3% reported in one report. And the recurrent episode of cholangitis probably due to a partial stricture or a injury to the ampulla, resulting in recurrent episodes of cholangitis in as high as 36% of patients uh, in a report published in 2011. So therefore, if you compare both the things, what is the current perspective of DPPHR? Okay, vis-a-vis pancreatic duodenectomy, there is less operative blood transfusion, reoperation rate is less, mortality is marginally better, and of course, what is important, where it scores over this procedure scores over pancreatic duodenectomy is a long-term metabolic derangement. So this can be considered as pros of this procedure, whereas cons are technically this is a much more demanding procedure compared to pancreatic duodenectomy. The risk of pancreatic jejunal, pancreatic jejunostomy leak is similar, because here again you have to handle this divided or the pancreatic remnant the same way as you do in pancreatic duodenectomy. Therefore, the incidence of leak as well as the complications thereof are the same. So overall, the immediate post-operative complications between the two procedures is no different. And what is important is in the DPPHR, as you look at this series particularly, there's a lot of lesions which may not, they are benign lesions, they may not really warrant resection. For example, serous cystic neoplasm, the recommendation is no intervention for this unless this is symptomatic. So therefore, for small SCN, doing this procedure is certainly not called for, not warranted. And again, with this procedure, if it is a malignant tumor or the pre-malignant tumor, the margin may get compromised. And what is again is more worrying is the duodenal ischemia in the immediate post-op of the delayed ischemic strictures of the CBD following DPPHR. And then long-term metabolic derangement, even if you think that's an important issue, but certainly these are all manageable complications. Diabetes mellitus, I'm sure, is not difficult to manage, nor is pancreatic enzyme insufficiency. So, and again, like this is the global scenario, like in this, what Vegas reported was 654 patients done over 15-year period. That means roughly about 40 patients per year globally. So not a very big figure. So, I mean, all that I can say, this is probably a casual surgery, not a very frequently done surgery. I conducted a quick WhatsApp survey before while I was preparing for this presentation amongst the leading GI surgeons and pancreatic surgeons in the country. Only 3 responded, and all of them had less than 10 cases done in 10 years, and these are the indications for which they are done. So, what is the final take on this procedure? Even the father of this procedure, Hans Beger, this is what he has written in his conclusion, that this has the potential to replace pancreatic duodenectomy. Certainly, he does not recommend even 20 years after he had he had performed this procedure. What he says that this has a potential to replace pancreatic duodenectomy for benign tumors and premalignant cystic and neuroendocrine tumors of pancreatic head. So if you honestly ask me what's going to be my take on this procedure, I can only say that, well, I'm not really impressed. I won't certainly recommend this. Maybe I'll advise you to master the technique of doing a good Whipple so that you have a good immediate post-operative outcome rather than, waiting for a long-term insufficiency and this derangement to happen. Thank you so much.
Thank you, Dr. Mohammed, and I would appreciate your frankness, because I was going to ask you, or rather the audience, how many people are doing it, because it seems very technically challenging, and especially to preserve the arcade. It's like doing a total paratectomy where you preserve the nerves, so similar things I was going through my mind when I was actually seeing the thing. So, yes, the answer is already given, so the forum is open for questions. Any questions from audience? Thank you. Thank you, sir. Thank you so much.